The third question I'm asking is, what is the primary treatment for low-grade serous carcinoma? And everybody in this room, I think, understands that, but just to review it, primary surgery is the preferred approach. Usually that's based on a diagnosis of an ovarian or ovarian masses on ultrasound, the CT, CA-125 is elevated, and it's important if a woman has those features that she be referred to a gynecologic oncologist. Over the course of my career, I've seen too many women who've been operated on by an obstetrician gynecologist thinking they had a benign mass, only to find low-grade serous carcinoma at the time of surgery. And what that translated into for many of these women was they had to undergo 2 or 3 surgeries when this all could have been done with 1 surgery. And so I think these criteria for referral from an obstetrician gynecologist to a gynecologic oncologist need to be refined, but certainly in practice they're far from perfect. The surgical procedure is if the disease seems to be confined to the ovary, once the surgeon gets into the abdomen, is a hysterectomy, bilateral salpingo-oophorectomy, omentectomy, and multiple biopsies and cytologies. That's in patients who seemingly have it confined to the ovary. But if a patient is young and has not completed childbearing, there are patients, unfortunately not as many as we would like, but there definitely are women who may have fertility-sparing surgery and have preservation of the uterus, 1 ovary, or at least part of 1 ovary. A number of our patients now, following their primary surgery with preservation of the uterus and ovary, for instance, are still undergoing oocyte retrieval and cryopreservation, just in case. But of course, if the tumor is metastatic, and that's usually very obvious at the time of primary surgery, then the goal is maximum cytoreductive surgery to achieve what we call no gross residual disease. So no, at the end of the surgery, the completion of the surgery, there's nothing that is either seen or palpable. However, we understand that that doesn't mean that there are not microscopic cells there. There always are going to be microscopic residuals, and so that's, of course, the reason for postoperative therapy.